I'm Catherine Santoro, Director of Policy and Development at the National Institute for Healthcare Management Foundation, and on behalf of NIHCM, welcome to our webinar today. It's becoming increasingly important for consumers to become more savvy healthcare shoppers. Healthcare spending continues to rise, with personal health spending per person growing 40% between 2006 and 2015. To control costs, there's a continued push towards consumer-driven healthcare and cost-sharing to engage patients in their healthcare decisions. Yet, few people search for spending estimates or compare costs before choosing healthcare services. We're pleased to have an excellent panel of speakers with us today to explore ways to empower consumers to shop for high-value healthcare. Before we hear from them, I want to thank NIHCM's President and CEO, Nancy Chalkley, and the NIHCM staff who helped convene this event today, including Kate Ellis, Katie McDonald, Carolyn Myers, and Kirsten Wade. You can find biographical information for all of our speakers, along with today's agenda and copies of slides on our website. We also invite you to live tweet during the webinar today using the hashtag #NavigatingCare. I'm now pleased to introduce our first speaker, Kristof, the Associate Director of Policy and of the Purchaser Value Network at the Pacific Business Group on Health. In these roles, he influences policy to improve quality and lower costs for some of the largest purchasers of healthcare services in the U.S. and identifies and engages large employers in best practices to improve consumer engagement to help promote value. Kristof?
Thank you, Catherine. As Catherine mentioned, my name is Kristof Stremikis. I'm the Associate Director for Policy at the Pacific Business Group on Health. For those of you who are not familiar with PBGH, we are a nonprofit organization that represents about 65 or 70 large public and private purchasers of care. We are a West Coast organization. We have our roots in the Bay Area, but we certainly, over the last 20 or 25 years, have become increasingly a national organization. So we're not only technology firms in the San Francisco Bay Area, but we're also manufacturers. We've got large retailers throughout the country. So when you think of PBGH, it's not just the Pacific Coast. It's really very broad industrial and geographic representation. A number of our members do believe in consumerism, and one of the ways that manifests itself is offering consumer-directed health plans. I think the large take-home that I, at least as a health services researcher before I came to PBGH, recognized is there is an increasing uptake in consumer-directed health plans and offering health savings accounts, health reimbursement accounts through the employer. You see this year after year after year. The slide in front of you is the most recent employer health benefits survey from Kaiser that came out earlier this week. And the take-home from this is an upward sloping line to the right, which essentially means now about one-third of the 160 million Americans who get their insurance through their employer are in some sort of consumer-directed product. Now, that's a fact, but there are two caveats to this that I would add. Large employers embrace consumerism, but with two caveats. Number one, with limits. So what I mean by that is our employers, and when we look across the country, employers as parts of other large coalitions, really have an upper limit in the amount of money they're comfortable having employees be directly exposed to. The slide in front of you comes from the National Business Group on Health, a large employer survey that came out about a month ago. And what you see in those green boxes right there, which are essentially the same size, is the amount of money that the employee is individually responsible for. Out-of-pocket costs has really been consistent year over year. So while you've got an increasing number, and if we go back, yes, there are more and more employees that are in high-deductible health plan arrangements, the amount of money that they're being asked to contribute or the amount of money that their out-of-pocket liability that they're exposed to is somewhat limited. So that's the first caveat. The second caveat, and related to that first feature, is employers are embracing this movement towards consumerism very, very carefully. Because when we look at the empirical literature, certainly it seems that high-deductible health plans and consumerism lower healthcare spending, but the vast majority of those savings are by reductions in services. Now, if those service reductions, if you're just getting rid of the tests and treatments that were unnecessary, that would be fine. But it's pretty clear that consumerism by itself is a blunt instrument. And so consumers will reduce consumption of both medically necessary and unnecessary care. They're not really price shopping. They're just reducing the amount of health care that they're getting. That's a problem for large employers, particularly if it's employees that have chronic illnesses, medically complex patients. If they're not getting preventative care, chronic care management services, you're maybe saving a little bit of money on the front end, but that's pretty superficial. And moreover, that's just not what we want employees to be doing. We want employees to be healthy. So with those two caveats, again, employers embrace consumerism, but with limits, and they're doing this very carefully because, again, it's a pretty blunt instrument. What are employers doing in this space? We don't have a ton of time to go through all of this, but I've outlined 5 major strategies that our members are experimenting with. The first is using transparency vendors. So they want to proactively disclose the price of a test or a procedure before an employee goes and gets care. They're using large vendors that I'm sure you're all familiar with. Price transparency is very, very important to employers, but it's necessary but not sufficient. You also need quality measures so that folks know whether they're going to be they're going to have a good experience, whether the doctor that they're receiving care from is highly rated, et cetera. I would say in general, employers are not happy with the amount of information that's available to employees when they're out there price shopping or when they're trying to get quality measures determining whether a provider is high performance or not. This manifests itself in unhappiness, I think, with the current tools that are available. And we're working with those vendors trying to address regulatory or trying to address barriers to disclosing information, sometimes by working with state or federal policymakers to increase the amount of information that these vendors can then disclose to our employees. I'll talk more about that in just a second. The second thing that some of our large members are doing is working directly with delivery systems to try to better activate and engage consumers. Some of our large members who you may be familiar with have actually entered into direct contracting arrangements with care systems in the Pacific Northwest, in the Midwest, in the Southeast. And as part of that, they've learned they've garnered some interesting insights into what exactly works when you're trying to engage patients, particularly those that are chronically ill or with medically complex patients. We've summarized some of the lessons from that experience and created a toolkit that's free and available to all employers and employer coalitions on the Purchaser Value Network and PBGH websites. One of the domains for ACO assessment is member identification and engagement. We've looked at what works, particularly for medically complex patients. How do you reach out to these folks? What type of information do you share with them? Who should be reaching out? What sort of language do you use? We found that the way you talk about things makes a huge difference. We've tried to summarize all of that, not only for large employers, but also small and medium-sized employers, so that when their carrier or TPA comes to them and says, we've got a great accountable care solution for you, which lots of carriers and TPAs are doing these days, this is a way for employers to lift the hood a little bit and ask some questions about, okay, how are you engaging members? How do you engage employees and promote consumerism within your accountable care system? Again, that's summarized in this toolkit, which is free and available on the PBGH website. A third thing that employers are doing, in particular employer coalitions, is trying to directly engage consumers themselves. Next Wednesday, we will be releasing an employer action guide for employers that want to promote high-value primary care. And one of the particularly cool things about this action guide is an appendix that we're including at the end, which is an employee engagement guide. It's a set of questions that employees that are shopping around for a primary care practice, looking for a primary care facility to be affiliated with, what are some questions that they can ask in 5 or 10 minutes of these practices to find out if they're delivering high-value care? Working with some folks out here in California, we went through the literature and found out the processes and procedures that some of these high-value primary care practices go through, and then developed a set of hopefully very accessible, quick questions that someone could ask over the phone when they're trying to determine whether a practice is adhering to these best practices or not. That's all summarized in a pretty slick-looking employee engagement guide that we're distributing to other coalitions and employers. And again, this will be released publicly and for everyone next Wednesday. So if you're interested in that, please look out for it on the Purchaser Value Network or PBGH website. The fourth of 5 strategies is that employers are taking to promote consumerism is actually trying to increase the amount of information, quality measures that are out there. The California Healthcare Performance Information System, something that's housed within the Pacific Business Group on Health, recently started publishing physician quality measures publicly for everyone to go look at. If you go to caqualityratings.org, the latest data that we have is up there. This collects information on clinical quality, screening rates, et cetera, for physicians in the state. It's not an all-payer claims database, but we've certainly got most of the payers in the state are participating in this now. And so this is a good example of employers trying to complement this shift towards consumerism, which in some cases, some people take just to mean employees being asked to shoulder an increasing amount of financial responsibility for care. This is employers saying, well, we need to make sure there's good quality information out there, too, so folks aren't shopping blind. The last thing that some employers are engaging in now is actually working with policymakers, because in some cases we're finding there is legislative or regulatory strategies that are needed to increase the amount of information that's available to folks to make them good shoppers, so to speak. That takes, we've worked on a number of different policies here, including eliminating gag clauses at the state level. We certainly need, if we're asking folks to shoulder their responsibility for their care, they need to know how much it's going to cost before they actually go and get the test or procedure. We've worked with policymakers at the federal level on reforms to the Qualified Entity Program. This is Medicare data that's published, that becomes publicly accessible. We've worked with policymakers to increase the amount and the way that data can be used and distributed to different folks. There are regulations around consumer cost sharing, particularly in high deductible health plans. There are some reforms to that that we think are needed. Again, going back to this idea that consumerism is somewhat of high deductible health plans can be somewhat of a blunt strategy where you're getting reductions in both necessary and unnecessary care. We want to make sure there are certain guardrails and actually encourage the continued use of high-value preventative care, chronic care management services, primary care, and high-deductible health plans. So making sure folks can go and get that care before they meet their deductible, so that we're not inadvertently reducing things that ultimately come back and cost us more at the end. That's a whole lot of information very quickly. There is more about all of these strategies, initiatives. There's a ton of information available on these websites, Pacific Business Group on Health website, the larger Purchaser Value Network initiative that PBGH is part of. And then some of our policy and advocacy work at the federal level is summarized at drivehealth.org. That's a partnership that we've entered into with the ERISA Industry Committee to advance some of the things that we think are needed, some of the federal policies that can complement this purchasing shift towards consumerism to make sure that consumers have the information that they need to be smart shoppers. With that, I will pause and turn things back over to Catherine because I know we have a pretty packed agenda this morning. Thanks, Catherine.
Great. Thank you so much. Kristof touched on the complexities of guiding consumers to choose high-value care, and our next few speakers will be sharing their research that can help inform efforts to engage patients in shopping for value. I'd next like to introduce David Auerbach. He's a health economist and Director for Research and Cost Trends at the Massachusetts Health Policy Commission. I first want to thank him for his help in pulling this webinar together and mention that he joins us today to share their research on consumer preferences and which incentives lead consumers to seek care in lower cost settings. David?
Perfect. Thank you very much, Catherine. Yes, this is research that we've undertaken here at the Health Policy Commission in Massachusetts, along with, as you see in the front slide, some researchers at Tufts University. And this is based on a grant from the Robert Wood Johnson Foundation. And I'll just say the Health Policy Commission, as I refer to the HPC in the slides, we're a state government agency. We were created in 2012 with the mission of lowering the rate of healthcare cost growth in the state. We have a target benchmark, and also improving the quality to the extent that we can. So here I'll be talking about one of our strategies of attempting to do that. Okay. So here, by way of background, the HPC has consistently found that community hospitals, and by that I mean non-teaching hospitals in the state, provide care of similar quality and lower cost than the teaching hospitals we have in the state. And I'll just note that I talk in this study a lot about AMCs. These are teaching hospitals that are connected to, that are academically affiliated, and we have a lot of them in the state. There are 6, and they account for about a third of all inpatient discharges. So this is probably a bigger deal in Massachusetts than other states, but in general, a lot of what I'll be saying, we've talked to folks around the country, and a lot of the same issues apply in other metro areas. We just tend to have some supercharged teaching hospitals in Massachusetts. So the problem, or something that we're trying to address, is that Massachusetts residents do use these AMCs and teaching hospitals for a high proportion of their routine care that could be easily handled at high quality in the non-teaching hospitals in the state. And you can see that 42% of our Medicare inpatient discharges took place at teaching hospitals, much higher than the national rate. And we've tried to do a number of things about this in recent years. We'd like that percentage to be lower, and we've fostered the growth of tiered and limited network products, which might charge higher copays or out-of-pockets when patients do use those hospitals, the teaching hospitals. We've tried supply-side methods, which are growing in the state, like alternative payment models that would place the provider groups at risk for these higher costs. And those strategies have been working, but they haven't changed the needle on the proportion of routine care taking place at these teaching hospitals. So we sought to try to understand what's going on and what would it actually take. Is this an impossible mission? What would it take to get some of that care back to the community hospitals? So I'm going to go through a little bit of background, and then I'll get to the study. So I'll go try to quickly through some of the background. And much of this is probably not going to be surprising, but here we've lined up, for example, just the cost per case mix adjusted discharge by group of hospitals. The AMCs are on the left. The costs are higher at just about all of them than they are at the community hospitals that are shown on the right. We don't see any relationship between these costs and quality if you look at readmissions rates or other indicators. So you have about $1,500 more on average for a discharge at an AMC. And those were overall for all discharges, but if you narrow down to specific things are some of the shoppable care, such as hip and knee replacements or low-risk births. You see the same patterns. You can look at procedures that could be performed in hospital outpatient departments versus in the community. This is another example of something that we looked at in the study that I'll get to. For example, MRIs, higher cost in the hospital outpatient departments. This is showing by each of those. Here are 5 of the 6 AMCs. The green portion is showing the percent of their discharges that are for routine low acuity conditions and that are for patients that are coming in from the suburbs into Boston. It's about a quarter to a third of the discharges that they have. And so that green portion is the portion of care that we're trying to shrink. Okay. And this slide just shows that it's been a growing problem. If you look, for example, at the proportion of births that happen at the community hospitals versus the teaching hospitals, it used to be about 3/4, and now it's about a half. And these are low-risk births. Another time trend showing that on the bottom, the proportion of low acuity discharges that takes place at the community hospitals used to be about 55% in 2011, and it's slowly dropping. So this routine care is increasingly going to the teaching hospitals. And there's a large amount of money that would be saved if you could shift some of those discharges. Okay, so there's the motivation. This study had 3 parts to it. The main part that I'll spend most of the time talking about was a discrete choice experiment, a survey to about 1,000 Mass residents where we asked them about their preferences and changed a number of parameters and saw where they would choose to seek that care. We also wanted to ground those the survey data in some real live empirical data, so we looked at the state's all-payer claims database to see if it was consistent. And then we conducted 8 focus groups to try to learn a little bit more in depth what was behind the numbers we were seeing. So for the survey itself, as I said, about 1,000 Mass residents we found across the state. We wanted to look specifically at those who would be in the commercial market where some of the incentives that we're thinking about would be able to have more play. We chose some standard average shoppable procedures that everybody likes, MRIs, uncomplicated delivery, knee replacement, and we also looked at a cancer scenario. And some of the things that we tested were impacts of out-of-pocket costs, and these are all impacts on hospital choice, as you'll see. Effects of referral from your primary care physician, who might be referring you to a specialist who is housed at one of these hospital types. We looked at quality ratings using stars and convenience in the case of MRI. And here's what the choice experiment might have looked like to a consumer. They're faced with a scenario, you need knee replacement surgery, and they're given a number of parameters about 2 hospitals that they have to choose between, a community hospital near their home and one of these Boston AMCs, and we listed them, and everybody's going to know them. And we varied the quality rating for the hospital. We varied whether they had a referral. We varied their out-of-pocket cost for the procedure, and then they were forced to make a choice. Okay, so before I show you the key results slide, which is coming next, I'll show you how to understand what those results mean. So if you imagine we're starting from a baseline where the characteristics of the 2 hospital choices are the same in all cases, and the results are relative to a situation where people are indifferent. So on the right there, you see, imagine the same number of people are choosing the AMC and the community hospital when the parameters are the same. And then I'm going to show you results where one by one we change just one aspect of the hospitals, for example, the out-of-pocket cost. And then the results are cast in a way that ask, well, if you change just that one thing, what percentage of the people who initially were choosing the AMC are now going to switch, are going to shift their preference to the community hospital? So we're going to show the results as a percentage. Okay, so I'll spend a little bit of time here. Here's what these results mean. So let's look at the blue bars, which show the difference for a $1,000 additional copay for the AMC. If you look at the maternity blue bar, for example, that says that if all else equal, if the patient were faced with paying $1,000 more to deliver at that AMC, about 28% would say, given that difference, okay, I would now actually prefer to deliver at the community hospital instead of the AMC. So that's a fairly strong, that's a fairly big response. And you can see for the other blue bars, a little smaller for knee replacement and smaller for cancer. The MRI was actually just a $100 difference, which is more relevant for out-of-pocket costs for MRIs, and that's a very big percentage of people who would shift. And one more difference, the MRI case was actually not cast between an AMC and a community hospital, but there we posed, would you have your MRI at a hospital outpatient department versus a freestanding MRI center? We then looked at the effect of a referral from your PCP. Here you see the highest effect was in the maternity scenario, where almost 50% would switch to a community hospital if they were referred there from their PCP, which is certainly related to, if your OB practiced there, and people often do choose their OB based on what hospital they deliver at. Knee replacement also had a fairly high effect of a referral from a PCP. The cancer scenario did not. And then we tested the quality metric where we posed for people. Imagine there's a 4-star quality rating for that community hospital compared to a 3-star rating at the AMC. And in that scenario, you see that there were high percentages that would shift to the community hospital in the knee replacement and the cancer scenario more than in the other cases. And so the big takeaway here is that these percentages are fairly large. And secondly, I would say, as you see on the x-axis there, these medical scenarios are arranged from left to right in terms of increasing risk to the patient. And you see a higher effective quality as you get towards the more invasive side, and a higher effective cost as you're towards the left. And that was something that we explored more in the focus groups, but it generally made sense to us. Okay, I'll try to go fairly quickly. This is testing different cost points, and just for the knee replacement in the maternity scenario, we actually had several cost ranges so that we could graph them out, and you can see that people were more responsive to, it's nonlinear, so that around $1,000, $2,000 had a big effect on people's choices, and beyond that you had a diminishing returns situation. Here I'll just note that in the side study we did on the Massachusetts all-payer claims database, the results seemed to be in a similar range. Although we couldn't do the same exact comparisons, we looked at people who did choose to deliver where they delivered, and about 20% did go to 2 of these AMCs, the Brigham and Women's and Mass General. And these choices were strongly influenced by whether there was a deductible in their plan, whether they were an HMO, and so on. And those impacted about maybe a third of the choices, which seemed in a similar range as the DCE results. Okay, so I skipped one, but we conducted a number of focus groups, and I'll kind of go fairly quickly through that, and they were quite interesting. And so before getting to that, a takeaway from the quantitative results do seem to suggest that people are quite responsive to incentives, that you would think that you'd be able to shift where they have their care, and so it kind of made us think, well, why is this so hard? Insurance, some of these parameters, such as these out-of-pocket, are typical differentials in tiered network products. So, what's really going on? And the focus groups kind of told us the answer to that, and there was a little more depressing, I would say. When you ask people about quality, for example, sure, they answered the questions, and where we told them the community hospital was better quality, but when you talk to people, they said, nah, I don't really believe that's possible. They have a very strong sense that the teaching hospitals are higher quality, and it's hard to convince them otherwise, even with the stars. And so that was just a factor that was difficult for people to accept. And they did also confirm that, for something like an MRI, they didn't think that quality made that big a difference, and they were more willing to move. But for something that was more invasive, it was a bit of a tougher sell. And here's a quote. Stuff like a broken bone or tonsils, I guess, would be something your local hospital could do. But something like cancer or heart surgery, you think, we've got to go into Boston to a big hospital. And that's sort of the attitude that we heard over and over again. Then another slide, we asked people about quality information, getting back at those quality star ratings. Who would you trust quality information from? And people trust their doctors quite a lot on everything. But when it comes to employers and websites, they're a bit more skeptical that what you're telling them about quality is really real. We delved a bit more about costs. After seeing those big effects of out-of-pocket, something that we learned was that, sure, if people are forced to make a choice about cost, then they would, but they really didn't like to have to make that choice. They know that these narrow network and tiered network plans will put those costs on them, and they just don't like that. They don't like having to make that choice. And something else that I'll get to, they didn't really tend to believe that if my employer has a narrow network plan that's cheaper, that those savings were going to come back to them in some way. They thought, oh, that's just some scheme for the insurance company to make money. I don't get any benefit from that. So they don't like having to make these cost trade-offs, obviously. And when we talked about referrals, confirmed that people did trust their PCPs, which they do. Interestingly, they said that when something was really complex or risky, they wanted to do some of their own research and shop around, and they really wanted to find out who were the best doctors, where can I go. So it kind of suggested that the referral effect should be stronger, as we saw in the results for some of the things that people felt were a little more routine. Here's a quote: I like having the choice. It's like I'll do the research myself depending on what it is. If it's something my eyes, I'm going to make sure it's a reputable place, try to get research on the doctor, and so on. Okay, so here's some overall findings. People will respond to cost differentials, quality signals, and referrals, but they perceive large quality differences between these types of hospitals. They prefer the AMCs for invasive and risky stuff, and they're skeptical of attempts to steer them. And we took away some lessons from some of this, and I think some of this is related to what Kristof was saying about the employers. You have to present the information to the employees in a way they'll understand, and if they can see clearly with a side-by-side, if you're in this tiered or limited network plan that's cheaper to you, I mean, first of all, there should be real savings to the person, and they should understand that if I am limiting my choices in some future scenario, I actually am going to have a financial benefit for that, because people start out very skeptical about it. Also, resulting from the study, those differences by level of risk suggest that you should place your financial incentives on the routine care and try to steer people there. And when you're talking about the more risky care, the financial incentives might not have much impact, and there you've got to really convince them on the quality. And people tended to have a sense that quality varied quite a lot, and that even what we think is routine, people thought was risky. And if you can push that boundary so that people realize that, some stuff that you might find a little scary is really done just as well in the community hospitals. It's a tough sell, but that would probably yield a lot of benefits. And given that people did trust their PCPs and those referrals, you'd like to have the physicians include cost in their equation, and there we're talking about the global payments and global budgets. People don't like the idea that their physicians are steering them based on cost, but that's just something to deal with and consider. Okay, so that's the end of the talk, and I think we're saving questions to the end.
Great, thank you so much. So as efforts to help consumers shop for health care ramp up, it's important to understand whether, as Kristof mentioned, the increasingly popular consumer-directed health plans are encouraging consumers to make value-based decisions about their use of health care services. And to share research on this topic, we're joined by Rachel Reid, an Associate Physician Policy Researcher at RAND Corporation. And I'd like to note that NIHCM Foundation provided grant support for Rachel's research on this topic through our investigator-initiated research grant program, and we're grateful that she's joining us today to discuss this work. Rachel? Rachel, make sure that your phone is off mute, please.
Oh, thank you. Thank you, Catherine. I want to start off by acknowledging my co-investigators, Neeraj Sood and Brendan Rabideau at the University of Southern California, as well as funding from NIHCM, as Catherine already mentioned, and my fellowship, Schaefer Fellowship between RAND and the University of Southern California. So, in the United States healthcare system, as we all know, waste is both common and expensive, with several studies estimating the cumulative annual burden of spending on waste in the range of $750 billion, or about 30% of annual healthcare spending. So eliminating waste is clearly seen as a promising way to save money by eliminating things that add little value to patient health, satisfaction, or well-being. While there are multiple contributors to that cumulative wasteful spending, a substantial proportion is traceable to overtreatment or unnecessary services or low-value healthcare services. So low-value healthcare services are tests or procedures that offer either no or unclear clinical benefit to patients, but at the same time still expose patients to both risk and expense. And that risk and expense can flow directly from the service itself, or it may flow indirectly through a cascade of additional services and procedures that might be triggered by the initial one. To walk through an example of this, we'll think about imaging for acute low back pain, and I feel like I should caveat myself after David's last talk that I'm a primary care doctor also at a Boston Academic Medical Center. So I do see patients present for acute low back pain. And one of the kind of, an example of a low-value service would be imaging for acute low back pain. Except in a small subset of situations, imaging actually, which means a X-ray, a CT scan, and MRI, rarely alters clinical management or identifies serious conditions. But at the same time, it exposes patients to both radiation and expense. And it may go on to find clinically irrelevant abnormalities that lead to further tests and procedures, referrals to specialists, or invasive procedures that themselves may offer limited benefits or carry risks, such as spinal injections or even some surgeries. Reducing low-value services offers an opportunity to increase quality of care, to increase access to care, while at the same time decreasing wasteful spending and unnecessary utilization. And then accordingly, efforts to try to reduce low-value services have been championed by payers and policymakers. But reducing low-value services first requires identification of them, and one highly visible effort to identify low-value services has been led by providers. The Choosing Wisely campaign was spearheaded by the American Board of Internal Medicine Foundation in 2012 with the release of top 5 lists from 9 specialty societies. These top 5 lists were services within that specialty's purview whose use should be questioned or at least mentioned in conversation between providers and their patients. And since then, the initiative has grown to include recommendations from more than 70 specialty and professional societies. And examples of the type of thing that you might see on one of these top 5 lists are from the American Academy of Family Practice. Don't routinely prescribe antibiotics for mild to moderate sinusitis unless the symptoms have lasted a certain duration or carry a certain clinical pattern. Or from the American College of Obstetrics and Gynecology, don't schedule elective, non-medically indicated inductions of labor or C-sections before 39 weeks. Identifying low-value services can be challenging and fraught, though. Some of these top 5 lists from certain specialty societies have been critiqued for being too cautious, or that they are focused on imaging, lab tests, or medications rather than physician services, or that they focus on things that are not necessarily commonly done. I'm presenting here the American College of Orthopedic Surgeons top 5 list, and if you look at it, it doesn't actually include any physician services there. Professional societies, in turn, cite concerns about making more broad, more daring recommendations for these top 5 lists, because they're concerned that the recommendations may be too broadly applied to payment or coverage decisions when there remain instances where a given service might actually be clinically indicated even if it's often low value, or that these recommendations could be marshaled for pay-for-performance or public reporting initiatives. Beyond the challenges of identifying low-value services, measuring and quantifying them presents a challenge, and there are 2 general approaches. Those numbers I presented at the beginning of the slide deck about the cumulative scope and scale of the problem of waste and overuse in the healthcare system, those derive from indirect analyses of waste. These are broad analyses of geographic variation in spending, and they're great for exactly that, getting a general sense of the scope and scale of the issue. But there's a big gap between those numbers and concrete opportunities for change. The other approach is to measure low-value services directly, that is, using defined measures of discrete low-value services. And that's helpful because it identifies specific opportunities for improvement. But it can be challenging to undertake on a large scale because many such efforts have relied on medical records data. There's a substantial body of prior research dating back decades that has used medical records to review and assess the appropriateness of tests and procedures. But direct manual review of medical records is incredibly resource intensive, and accordingly, records-based assessments of the appropriateness of medical care have been limited in size and scope. More recently, some of my colleagues at RAND have looked at the feasibility of using structured electronic health record data to turn some of the Choosing Wisely recommendations into e-measures. And they actually found some challenges in that the amount of, the fraction of Choosing Wisely measures that were readily marshalable into e-records, e-measures from EHRs was relatively small. But measuring low-value services directly using insurance claims provides an opportunity to look at specific concrete examples of clinical care while maintaining a large scope and scale to your analysis. And a new and growing literature is starting to do just that. And this is what we undertook. So we looked at health insurance claims from approximately 1.5 million adult patients from a large national commercial insurer. And we used that data to assess 28 direct measures of low-value healthcare services. These measures represented an array of commonly used services from different types of care, including imaging, laboratory, and other testing and procedures, and then covered a broad range of clinical areas. And the measures derive from a variety of sources, the Choosing Wisely recommendations, U.S. Preventative Service Task Force Level D recommendations, those do not do recommendations, the peer-reviewed literature. And we set out to answer 3 key research questions, and those were, how many patients get low-value services, how much do those services cost, and which patients got more low-value services. On the whole, we found that 7.8% of the patients we assessed, or about 115,000 of our population, received at least one low-value service during the year we looked at, which was 2013. But that the impact on spending was modest, accounting for about 0.5% of their overall spending, or $32.8 million in that population of patients. It's important when you're thinking about that number, though, to keep in mind that we're only looking at 28 low-value services here. And while these services span a broad array of clinical conditions and types of care, they still only represent a narrow slice of all the types of low-value care that's used in the U.S. healthcare system. That said, among the services we assessed, the 3 most commonly received were T3 measurement in hypothyroidism, which is a type of duplicative hormone measurement for that condition, imaging for nonspecific low back pain, and imaging for uncomplicated headache. And all of these occurred in about 1 to 1.5% of patients during the year. And then the 3 services that accounted for the most low-value spending among those services we assessed were spinal injection for low back pain, imaging for uncomplicated headache, and imaging for nonspecific low back pain. And together, these accounted for more than 50% of the low-value spending in our population. We also observed that some key patient groups spent relatively more on low-value healthcare services. White and higher income patients spent relatively more than other groups. And this is important because it could constitute reverse disparities, with more privileged groups getting more wasteful care. We also saw that areas of the country that have relatively higher medical spending in general also have higher amounts of low-value service spending. And this is important because it means our analyses that are directly assessing measures of low-value services mirror the patterns of those indirect analyses that I referenced earlier. We also saw that some groups tend to spend relatively less on low-value services, and this included older and male patients, as well as those who were enrolling in consumer-directed health plans. And we found that CDHP result compelling. So we took a deeper dive to investigate into what's going on. Understanding how patients respond to consumer-directed health plans is important because, as was mentioned earlier, they're growing and have increased more than 6-fold over the last decade in the employer-sponsored market. Many enrollees from the individual marketplaces are in these plans, and they continue to feature prominently in Republican plans for healthcare reform. And we already know from existing research that CDHPs appear to save money because patients in them tend to use fewer services. But that work has also shown that when patients cut their healthcare use, they don't spare high-value services like preventive care or chronic disease care, and decrease their use in about the same proportion as their care in general. And this has led to the summary that patients tend to cut both high and low-value care when they enroll in a CDHP. But no one had previously looked at low-value services directly for CDHP enrollees. If CDHPs are making patients into more savvy shoppers, then they should be disproportionately reducing use of these low-value services that otherwise shouldn't be happening at all. So to test that hypothesis, we took advantage of a natural experiment when a group of patients in a traditional insurance plan switched to a CDHP, and we compared them to a group of matched patients who remained in a traditional plan. We looked at the change over time in spending between the two groups of patients. And if CDHPs affect spending either on overall outpatient spending or on low-value service spending, then we'd see a different change over time in spending between the two groups. We ultimately found that patients who switched to CDHPs decreased their overall outpatient spending by an average of about $100 in the year following the switch. But the patients who remained in a traditional plan actually increased their spending over the same period of time. So switching to a CDHP was associated with a significant reduction in overall outpatient spending, and this is consistent with what's been found in prior research. But when we looked specifically at the change in low-value spending over time, both groups reduced their low-value spending a little bit over time. So switching to a CDHP was not associated with a significant change in low-value spending. So consumers are not targeting low-value services in particular to cut. And we parsed the low-value spending into several different categories to see if that pattern was consistent. And we found the same pattern, decreased overall spending, but not low-value spending for laboratory services, in particular, imaging services in particular. And then we looked at services that might be more sensitive to patient preferences, things that the patient might ask for, as opposed to things that the clinician is potentially the most prominent driver of. And we didn't find a difference between services that were more or less sensitive to patient preferences. So CDHPs do encourage patients to cut spending, but again, they seem to do it indiscriminately and are not specifically reducing spending on low-value services in particular. To focus specifically on cutting wasteful spending might require different or more nuanced insurance designs with targeted cost sharing for low-value services as compared to high-value ones. Or an understanding of practice patterns so that we can design provider-facing programs to reduce use of those low-value services. Thank you so much.
Thank you so much, Rachel. We're going to turn next to hear about a benefit design tool to help consumers shop for care called reference pricing. And joining us today to share his work on this topic, including recent research on its application to prescription drugs, is Kristof Whaley, an associate policy researcher at the RAND Corporation. Chris?
Great. I'm excited to talk about reference pricing and consumer use of low-price providers and services. And just for acknowledgments, the research that I'm going to be presenting today has been funded by the Agency for Healthcare Research and Quality, the California Public Employees Retirement System, the Laura and John Arnold Foundation, and the Robert Wood Johnson Foundation. So we're grateful for their support. This research is also joint work with Jamie Robinson and Timothy Brown from the University of California at Berkeley. The whole idea behind reference pricing is that for the commercially insured population, there's a lot of variation in prices. And so for common and shoppable services that we think have lots of easily substitutable alternatives, prices vary pretty substantially. It's not uncommon to find a 10x difference in prices, even within the same geographic market for common services. Often there's no quality component, or this variation in prices is not linked to quality at all. Reference pricing is one potential response to this level of price variation. Reference pricing was originally developed in European pharmaceutical market context, and in the United States has been applied by several self-funded employers to a variety of services. So probably most notably, the California Public Employees Retirement System has applied reference pricing to knee and hip replacement services. CalPERS has also applied reference pricing to outpatient surgery, so for example, colonoscopy, joint arthroscopy, and cataract surgery. Safeway, the nationwide grocer, has applied reference pricing to lab and imaging tests. And more recently, the Reid Trust has applied reference pricing to pharmaceuticals. Reference pricing is driven by variation in prices. And just to illustrate that, this figure plots prices for colonoscopy services faced by the CalPERS population in 2011 which was the year before reference pricing was implemented. This figure plots prices for ambulatory surgical centers, which are freestanding surgical centers, in the red dots, and in the blue dots for hospital outpatient departments, or HOPDs, which are a traditional hospital. There are two main things to note in this figure. So one, for both types of provider groups, prices vary quite substantially. So prices range from around $500 all the way up to $9,000 or $10,000. And so there's a wide degree of price variation for colonoscopy services. The second thing to note is that almost uniformly, prices for ASCs are quite a bit less than prices for HOPDs. So on average, the typical ASC price is a little over $1,000, whereas the typical HOPD price is around $3,000. And this variation in prices isn't linked to any differences in the quality of the colonoscopy or the quality of the patient experience. So from CalPERS' perspective, this variation in prices in some sense represents a fairly sizable waste for colonoscopy spending. This next slide shows variation in prices within therapeutic drug class for the Reid Trust population in 2012, which again was the year before they implemented reference pricing. This table shows for the top 10 most common drug classes the range in prices between the lowest priced and highest priced drug within each drug class. So for example, for statins, prices range from $12.30 for a 30-day supply to $447 for a 30-day supply at the upper end. This variation in prices is due to differences in brand to generic utilization, but even within generic drug classes, there's still quite a bit of variation in prices. So reference pricing is one potential response to this level of price variation. And for predefined and shoppable services, so for example, colonoscopies and prescription drugs, the payer, in this case the insurer, the employer, sets a maximum reimbursable amount, which we call the reference price. Patients whose care costs less than this amount pay normal cost sharing, for example, copays, coinsurance, and deductibles. However, patients who go to a provider with a price above the reference price pay normal cost sharing up to the reference price, plus the entire difference between the provider's price and the reference price. So in some sense, the payer says that we're going to reimburse a certain amount for the procedure, and if you as a patient want to go to someplace more expensive, then you can pay for that difference. Many programs offer an alternative provider that is not subject to reference pricing. So for example, CalPERS exempted ambulatory surgical centers entirely because they cost so much less than hospitals, and so simply directing people to an ASC is one way to save money without complicating the program. Similarly, Safeway simply directed patients to the nationwide lab retailers like Quest and LabCorp. The fairly sizable potential increases in cost sharing due to reference pricing do have a pretty strong response in how patients shop for care. So this figure shows the impact of reference pricing for colonoscopies. And we have two populations plotted here. So first, in the red line, we plot the average price for the CalPERS population, which was subject to reference pricing in 2012. In the blue line, we plot the average price for colonoscopy services for our comparison group of Anthem enrollees who were never subject to reference pricing. Before reference pricing was implemented, prices increased steadily at about 5% per year for both CalPERS and non-CalPERS population. Following the introduction of reference pricing, prices for the Anthem population continued their steady increase. However, for CalPERS, there was a noticeable decrease in prices. And so this difference in price trends leads to about a 20% reduction in the price for colonoscopy, which we can think of as the savings for reference pricing. This chart shows something similar for pharmaceuticals. And this figure plots the share of prescriptions written for the lowest priced drugs within a given therapeutic class. And this figure plots the utilization trends for two populations, the RETA trust population, which was subject to reference pricing in July of 2013, and our comparison group of a large union trust population that was never subject to reference pricing. Prior to reference pricing, use of low-priced drugs was relatively similar between the RETA and union trust populations. However, following the introduction of reference pricing, there is a noticeable increase in the use of low-priced drugs by the RETA population of about 6 percentage points. The increase in low-priced drugs and the introduction of reference pricing had meaningful impacts on spending. And so this figure plots for the same RETA and union trust populations, trends in monthly drug prices in the top two lines, and patient co-payments in the bottom two lines. In the top two lines, when we look at total prices, prices were declining slightly in the time period before reference pricing, which is mainly due to the introduction of new generic drugs. However, following the introduction of reference pricing, there was an even greater reduction in prices for the RETA trust population in the blue line. If we look at patient co-payments, price trends were roughly the same between the RETA and union populations in the period before reference pricing. However, we do see a small increase in patient co-payments for the RETA trust population. And so overall, if we look at total prices, there's about a 14% reduction in overall prescription drug prices, which translates to a little over $9. If we look at patient co-payments, there's about a 5% increase in patient cost sharing, which is a little under $1. Overall, we find roughly a 15 to 20% reduction in prices due to reference pricing programs. This figure plots or lists several different procedures, the percentage point increase in the use of low-price facilities or treatments due to reference pricing, the percent reduction in prices paid per procedure or test due to reference pricing. In the third column, the total spending by the commercially insured population for these procedures. And then in the last column, our estimate of the potential spending reduction from reference pricing if we were able to achieve roughly the same effects. So for example, for joint replacements in the top row, we find a 14.2% reduction in the use of low-price hospitals, which leads to a savings of 19.8%. Among the entirely commercially insured population, joint replacement procedures account for a little over $17 billion in total spending. And so if we're able to achieve roughly the same effect, we estimate that reference pricing, if applied nationwide for joint replacement, could lead to a $3.38 billion reduction in spending. Overall, with the exception of prescription drugs, the procedures listed in this table for which reference pricing has been applied represent a little over $100 billion in total spending for the commercially insured population. And so we estimate that there could be about a $19.6 billion reduction in total spending if reference pricing were applied more broadly. So we estimate that if reference pricing were expanded to the same services that we previously evaluated, and we were able to achieve the same effects, medical spending could decrease by almost $20 billion, which is approximately 2.2% of total medical spending for the commercially insured population. If reference pricing were applied more broadly, beyond just the services listed in the previous table, spending could fall by around $76.2 billion, which is about 8.6% of total medical spending for the commercially insured population. And we also want to note that expanded reference pricing programs, especially if we're thinking about much broader expansions, are likely to exert pricing pressure on high-priced providers and give them an incentive to lower the prices. So if a reference pricing program were to be expanded or to be implemented, there are a couple things to keep in mind. So in order to have a successful reference pricing program, it's important to think of shoppable services. So, for example, it makes no sense to apply reference pricing to emergency services or services where patients don't have many options. Reference pricing should only be applied to services where quality is measurable, so you can examine if there are quality impacts of the program. Patients need to have price and quality information to navigate reference pricing programs, and patients have to have access to a sufficient number of low-priced and high-quality providers. Patients with special needs should be exempted from the program. So, for example, CalPERS, Safeway, and Reid automatically exempt any program or any patient whose doctor recommends care at a certain provider or a certain procedure. And finally, reference pricing programs should really aim to simplify the choice process. CalPERS, Safeway, and the Reid Trust all direct patients to specific providers or treatments. For example, CalPERS sends patients to ambulatory surgical centers. Reference pricing does have several limitations, so not all procedures are shoppable and thus relevant for reference pricing programs. Reference pricing does expose consumers to potentially high out-of-pocket payments. And finally, reference pricing places the burden of responding to price variation entirely on the consumer, rather than on health plans or employers for negotiating better prices and regulators for addressing provider market power and consolidation, which are the underlying factors that we think lead to higher prices. If you're interested in learning more about reference pricing, these are the 3 studies that I've mentioned in this talk. And I've also included a link to the Berkeley Center for Health Technology website, where we discuss many more of the implications of reference pricing.
Great. Thank you so much, Chris. So how can we practically use this research and these tools to facilitate healthcare shopping? Our next speaker is the Healthcare Service Corporation, which operates Blue Cross Blue Shield plans in 5 states, and they're a leading innovator in consumer engagement solutions to manage healthcare spending. We'll now hear about some of their efforts from Tom Meier, Vice President of Market Solutions. Tom?
Thank you, Catherine, and thank you to NIHCM for including us. You certainly heard a good deal today, and my hat's off to my fellow presenters about all the opportunities there are to avoid low-value services, direct folks to optimal sites of care, and really take the waste out of healthcare spend. And so, as Catherine mentioned, I wanted to provide perspective on how health plans and others in the healthcare industry are developing solutions to help encourage that active consumerism that we so desperately need based on the opportunity that you've heard. And we believe here at Healthcare Service Corporation, consumer engagement, active transformation into active consumers of care is essential. So let's go ahead and get into it. So in terms of who HCSC is, as Catherine mentioned, you likely know us better as Blue Cross Blue Shield plans in Illinois, Montana, New Mexico, Oklahoma, and Texas. We have several subsidiaries as well. We do provide healthcare products and our related services to both employers and individuals. We're the largest customer-owned health insurer in the U.S., 4th largest overall. So in terms of what that means, it means first and foremost we're part of the Blue Cross Blue Shield system. And that provides us with tremendous opportunities in terms of deeper insights, influence, and impact that we can make on healthcare. And so you see some of the numbers here. We have over 100 million members in the United States in our Blue Cross Blue Shield plans. We partner with over 1 million providers. We're in every zip code in the U.S. and 190 countries and territories. And again, what that ultimately relates to is data. It's data and insights and things we can do with that information. And so when we think about how can we transform healthcare members to truly become active consumers of care, it starts at the foundation at the bottom of this slide. We leverage that network. We leverage all of the data that's part of it, and then we partner with providers, we partner with employers, and we partner with the members themselves in terms of trying to drive some of that change. So whether it's how we are partnering with providers in things like centers of excellence, developing them, moving members to them, whether it is partnering with our providers as they move from fee-for-service into value-based care, whether that's patient-centered medical homes or accountable care organizations. We partner with employers. So you just heard about innovative benefit designs like reference-based pricing, flexible networks, tiered networks, smart networks. We're actively partnering with our employer groups when it comes to their benefit designs. And then finally, none of that works if we can't engage the member. If we can't engage that individual to make decisions, get care, and live healthy, then all of this is for naught. We're not going to be able to realize that huge opportunity. And so what I'll focus on today are some of the tools, programs, and services that are ultimately helping our members navigate their healthcare options and make better informed decisions about their health and their care that they're striving to receive. So what you see here is our healthcare journey at HCSC and how we have moved from these tools. So from left to right, you know, anytime you're a health plan, your number one tool is always going to be your provider finder, your ability for a member to come in or call or digitally look and understand, is their doctor in network? That's the one thing that members often do know about how to use their health care benefits. But instead of just answering that in a binary yes-no way, what we try to do and have been trying to do in our healthcare journey is leverage that as an opportunity. Leverage that as an opportunity to educate. Leverage that as an opportunity to inform the member, yes, your provider's in network, but here's some other information about quality about that information. Here are patient reviews, what other folks like you say about that provider. And just as importantly, here's some information about costs. How much this provider costs compared to other providers. But we quickly realized that that wasn't enough, and that ultimately for a member to really use this information, it has to be personal. It has to be personalized to them. And so we started to not only take all the information we have on our providers, but then overlay it with the member and with their benefits and what their benefit designs are, where they were in their deductibles, their out-of-pocket maximums. So now I can very much personalize what does it mean if I go to Dr. Jones, who I was searching for, and then also provide some alternatives with Dr. Smith and Dr. Young who do the same procedure, and what's it going to cost if I go there? And did you know Dr. Young actually performs the same procedure or service at the hospital outpatient setting as well as a freestanding ASC? And he charges two different rates. And now I can inform that member even more in a very personalized, meaningful, realistic way. But again, we quickly realized we can build these solutions, but what happens if they don't come? What happens if it's not in the channel that that member ultimately prefers? And so we launched our Benefits Value Advisor, which provides our members with a concierge advocacy solution. We don't wait for our members to use the tools. We don't wait for our members to call up and say, I'd like a quote on an MRI. Instead, both inbound and outbound, we engage with those members because we know if they're calling to get an ID card, or if we know that they're calling to understand what their benefits are for a procedure or service, they're almost assuredly likely that they're about to get a procedure or service. And now we can have a conversation and engage with that member before the choice is made and not wait until after and explain why their EOB out-of-pocket costs are so high. Sometimes that's not enough, though, right? Because while Ultimately, benefit design will have a huge impact, as you just heard on reference-based pricing. What happens if the benefit has already been maximized? What happens if that member has a low deductible? What happens if that member's already met their out-of-pocket maximum? What's in it for the member to actively engage? And financially, we can provide member rewards, and it's just what it sounds like. We're able to help members engage in their health care, shop for health care, look at shoppable procedures, understand the variance in cost and quality, and if they're making then an optimal choice, provide them with a cash incentive outside of, in addition to their benefit design, to encourage this active engagement, active consumerism. And that's led us now all the way to the right to our health advocacy solution programs, which combine all of these programs you see on this screen, along with some of our cutting and leading clinical algorithms to really manage that member holistically and be able to drive savings not only by eliminating unnecessary care, but also redirecting care to optimal places. So these programs represent our journey. It represents what we have in place today when it comes to solutions for our employer groups and for our members. And we're seeing exciting results. We're seeing programs like Member Rewards, which just launched at the beginning of this year, already realize over $500,000 in claims savings, and that's net. So that's after we're able to steer them to an optimal provider and pay a cash reward. We're seeing our benefits value advisor programs, which have been in place for several years now, continue to generate positive ROI. And they're not viewed, to some of the earlier conversation as a burden. If anything, it's a value add to the member. We're there to be their advocate. We're there to help them maximize their health care benefits, help save the member money in addition to their employer group money. And finally, our health advocacy solutions, which don't even officially start until next year. We've had some early adopters who are seeing significant cost savings reduction, both by eliminating unnecessary care and redirecting to optimal sites of care. So when it comes to this opportunities, I believe, and I believe HCSC believes, you have to have solutions. You have to have solutions that actively engage members, because otherwise you're developing or you're seeing all the opportunity and you're not realizing it, or you're developing solutions and they're not being used. And so it's really developing those solutions, providing something in it for the member to use them, and we believe by doing that we're going to be able to really drive active consumerism and hopefully take some of the waste out of the healthcare spend. So with that, I'll send it back to Catherine.
Great. Thank you so much, and thank you to all of our speakers. We're excited to now engage in a Q&A session with our audience. Please continue to submit your questions in the Q&A box, and we'll try to get through some of them. And if our speakers want to come off of mute, the first question for Chris Whaley, there seems to be significant price reductions with the application of reference pricing for laboratory tests, and could you speak to what tests are included in that category and sort of the potential?
Yes, so in Safeway applied reference pricing for laboratory tests to the most common sets of lab tests, so this is not all lab tests, but things like lipid panels, HbA1c tests, et cetera. And laboratory tests seem to be one of the most commodity-type services in healthcare, in the sense that there are multiple providers who perform the exact same test, and there's really no quality component. And so in some sense, it wasn't really surprising to see that for things that are essentially commodity, where there is a huge range in prices, we saw fairly sizable reductions in prices.
Great, thank you. A question for David. Your cost data for academic medical centers from 2013, are you tracking, or do you have any sense of if current data and trends, current data are demonstrating the same trends?
Yes, we do. We track that very closely, and I would say people can look on our website and find cost trends reports from the HPC, which have updated data. But in general, the price disparities between the higher cost, the higher price places and the lower price places have been pretty stable across 12, 13, 14, 15. Interestingly, there's been some legislative suggestions that aren't really near passing, but to actually regulate those price differences and try to have a maximum or a cap or something, those are probably unlikely to pass. But again, as I mentioned so far, a lot of the attempts to try to reduce the price variation hasn't had much impact. So those differences are persistent.
Okay, thank you. I think this question is for Kristof from when you were talking about employers looking to consumer-directed health care, but also watching kind of reduction in use of preventive care and high-value care. And could you speak to sort of what evidence exists or what evidence are employers looking to, or do they need to really understand if embracing this sort of consumer-based health care will drive down costs?
I think the empirical literature is pretty clear on this point, and we heard it from a couple folks today that consumerism, if by consumerism you mean just exposing people to a greater proportion of the cost, or the cost of the care is more directly borne by them, that's a blunt instrument, and so you get a reduction in both necessary and medically unnecessary care. I don't know that there are any questions about that right now. The general concept, there aren't questions about how much unnecessary versus necessary care is reduced. There is some argument there, but I think the overall concept has been proven pretty well. And I think that fact is why you see some of these data points now that show that even as employers are embracing consumerism through the use and offering of consumer-directed health plans, you've actually now brushed up on an upper limit, and what I think an upper limit of what employers are comfortable exposing employees to in terms of out-of-pocket costs. And so the way they're mitigating that is by increasing their health reimbursement contributions, by limiting the amount of the deductible, because employers are certainly not just interested in lowering healthcare costs at sparing no expense to do that. They really do care about a healthy and productive workforce, and I'm speaking for all employers in PBGH, which again include both high-wage technology firms, lower-wage retail sector employers. Really, they all are very careful about this because I think the studies are pretty clear. And in terms of which specific studies we're looking at, a number have been referenced today, but if you go back and look through the slides, there are source notes out there that you can go through and look at.
Great, thank you. And another question, can any of the speakers expand on the how of consumer education to engage in high-value care shopping? Not all consumers understand what is high and low value. What's the education approach? And, thinking about the choosing wisely, can you talk about, the provider side and the direct patient education that's occurring? I don't know, Rachel, if you want to take a first stab at that.
Sure, yeah. So specifically with the choosing wisely and kind of putting on my primary care provider hat here as well as my health services researcher hat, I think the intent of that campaign and the way that I think it can be marshaled well is that to kind of prompt conversations between patients and providers about, to kind of talk about kind of services before you order them or before you pursue them. 100% right that in plenty of instances, patients aren't, there's built-in asymmetries of information in the practice of medicine, and patients aren't always in a position to kind of weigh what is high or low value care. I brought up that thyroid lab test being one of the more commonly ordered low-value services. So I think in terms of patient education about particular services, that has to occur in the context of provider education as well, and kind of in outreach to providers, and kind of understanding which providers are providing more or less low-value services might be an important next step to figure out how to reduce that use.
Great.
Could I comment on that one?
Sure.
This is David again. Thanks, Rachel. That's actually that's a nice segue to what I was going to say. In some work that we did at the HPC, also we looked at low-value care, and we were able to connect it to the different provider groups by using the all-payer claims database in the state. A lot of the same measures you talked about, and once we then compiled the data that way and identified which provider groups had lower rates of some of the same things and which ones had high rates, and we called them up on the phone and said, what are you guys doing? How do you identify these services and engage your physicians and the patients? And a lot of them were using alerts in their electronic medical records, and they would program in, the conditions for the low-value care service and whether things were indicated or not. And these alerts would pop up, and the physician would notice that. And I guess the way it would work would be that it would at least prompt a conversation between them and the patient. And I think that is important because, like you were saying, with a lot of the consumerism approaches, the patient isn't going to realize what's really discretionary and what's possible and not. And you need to engage the physician as well, and that's probably a good way to do it.
Great, thank you. And Tom, maybe you could expand on that a little bit, and I'm also going to tack on another question since, you're dealing with a diverse population across different states and different types of plans and members, and could you speak to the high-value, low-value question, and also sort of how do you deal with providing information to people that either have low literacy or low health literacy?
Yeah, so great question, Catherine. So, I'd actually, expand on what David shared earlier when it comes to what's meaningful to a consumer. And that's going to vary. It's going to vary by consumer. It's going to vary by procedure service. So you saw sometimes it's all about the cost. If it's believed to be a commoditized procedure or service with low quality variance, sometimes it's all about the quality. If it's highly personalized, if it's something that's going to require really intense medical intervention. And so one of the things that we try to provide are all of those things. And then we let the consumer ultimately choose, well, what's going to influence them? And I think our research does show across that diversity, sometimes it's all about the cost. And that might be absolutely the case for one population. Others are influenced absolutely by quality, and we try to provide third-party objective quality standards that they can reference. And sometimes it's actually more of a social network, and it is all about patient reviews. They want to hear from others about what they said about that facility, what were their experiences with that provider. And so we try to provide all of those solutions in a very intuitive way. We don't want members to have to expand and go 10 clicks to find this information, because remember, all they were doing was calling to see if they could get a new ID card, or all they were doing was trying to understand what their benefits were or what their doctor and network. But we want to take advantage of all those opportunities and have a conversation, provide the member with all of that information, and really allow that member to decide what's most important to them so they can become that active consumer of care.
Great, thank you. We had another question. How applicable are strategies like reference pricing in rural areas where provider networks are limited? And are we going to see more employers encouraging people to travel for care, referencing the recent LA Times story about a woman in Santa Barbara County that traveled for a cheaper knee replacement surgery? I don't know if Kristof or Chris want to comment on that.
This is Kristof. I'll jump in for a second and then let Chris go ahead and talk about or address the reference pricing issue. When it comes to centers of excellence in travel surgery, certainly an increasing number of employers are exploring that and actually offering that to their employees. So we here at PBGH, 4 or 5 of our employers participate in an employer-driven center of excellence network where they're looking at quality, they're looking at price, they're looking at patient outcomes, and they're providing that information transparently to their employees and encouraging them to go and get care at these facilities. Now, whether that's a strategy that can be adopted by many employers across a range of conditions, I don't know. I think there are limitations to the travel surgery model, just as there are limitations to reference pricing. As Chris mentioned, it only works really with so-called shoppable services. But certainly it's something that a number of PBGH employers have looked at, a number are offering now, and they've experienced pretty good results.
Just from the reference pricing standpoint, California is a fairly geographically diverse state and does have a lot of rural areas. And so CalPERS early on made a decision that if there is no low-price provider within 30 miles of your home address, then you're automatically exempted from the program. And so I think those types of guardrails that are put in place are important to ensure that reference pricing programs work well for patients and also the employer or the payer. I do think also that programs like Centers of Excellence, or as Tom mentioned, rewards, where you're giving patients a financial incentive instead of a increased cost sharing to go to low price providers, can also be another innovative way to help spur patients to price shopping.
Great, thank you all. Another question, just if anyone wants to speak to the sort of the challenges of measuring and reporting on quality. There are, so many different groups collecting quality measures, and also how do we get consumers to care about that information? David mentioned some of their research, and how do you kind of overcome barriers of who's a trusted source of quality information? Maybe, Kristof, do you want to talk about your quality database that you mentioned in California and sort of how that's working with, other quality measurement organizations?
Well, I don't know that I have anything brilliant to add here, but I will say 2 things. First of all, there are certainly acknowledge the difficulty in getting consumers good information on quality. I think that's inherent to the challenges of measuring what good health is. And so there are difficulties, but that doesn't mean that we can't try, and there aren't very valuable measures that consumers can use to determine quality. One set of measures that we like in particular and that employees of PBGH members seem to like are patient-reported outcomes. So I think David or someone else mentioned this, but you're following up with patients and saying, how was your experience? Would you go back to this doctor? Would you recommend it to someone else? Folks appreciate that information. We still see the research, though, that says even if you do put this kind of stuff out there, people are still predominantly rely on referrals from their friends and family. I don't know that that necessarily should stop us from continuing to develop better quality measures, particularly patient-reported outcomes, and increase the amount of information that's available. So there are certainly barriers, but that doesn't mean we shouldn't continue in this effort because it's very worthwhile and necessary.
I could comment on that too. This is David again. We do find that there's this big gulf between the quality measures that all of us researchers run around with our HEDIS process measures of stuff, and then you talk to people and they think about, well, where did this doctor go to medical school, and they'll look up Yelp ratings on the website, and did people think that the doctor paid attention to them, and do they like them? And then I actually think that, Kristof, you guys were developing or working with someone to have a nice maternity intervention where you talked about some of the quality measures there that people really seem to be able to relate to, such as rates of complications and unnecessary C-sections and various things, and you made it really relatable. And I think that you have to find somewhere in between the process measures that nobody understands. And I think this doctor is great, and I think people are working very hard on trying to figure that out. And I think that's the area you have to go for.
Thank you all, and thank you for all your thoughtful responses to the questions and for taking time to join us today and share your work and your research. We really appreciate it. We are out of time, so I do want to ask our audience to take a moment to share feedback from this event. There's a brief survey that you can find on the bottom of your screen. There is a survey button. You can also find copies of the presenters' slides on our website, and a recording of the event will also be made available if you missed any of the presentations. Thank you all again for joining us today.